we are discussing today peripartum acute heart failure and its management. This is a very special scenario where pregnancy, another life is associated, the fetus. And this is peripartum acute or subacute heart failure. So these all patients of peripartum heart failure, the symptoms and signs of acute heart failure should be evaluated, and according to acute heart failure guidelines. So common etiology is peripartum cardiomyopathy, valvular heart disease with decompensation, pulmonary embolism, myocarditis, pre-existing idiopathic familial dilated or acquired cardiomyopathy, Takotsubo, pregnancy-associated MI, amniotic fluid embolism, and hypertensive heart disease or severe preeclampsia. So other than PPCM, these situations can be easily differentiated by simply doing a ECG, 2D echo, cardiac markers. So PPCM is a diagnosis of exclusion actually. There is no known cardiac disease, no heart failure signs and or symptoms prior to pregnancy. And towards the end of the pregnancy and the months following delivery, the typical onset is there, and elevated natriuretic peptides you will get, and reduced systolic function less than 45%. So this is diagnosis of exclusion when other causes are excluded. So other causes may be the myocarditis, like prior viral infection history will be there, and acute or subacute onset of viral infection along with the elevated troponin and elevated CRP, and there may be normal or reduced systolic function with typical myocardial late gadolinian pattern, and pericardial effusion may be there, and then cardiac MRI or myocardial biopsy in rare cases. Then another DD is the pre-existing idiopathic familial dilated or acquired cardiomyopathy. So you will have the history of previous known heart disease prior to pregnancy, and onset is typical second trimester, elevated natriuretic peptide will be there, and reduced systolic function, RV dysfunction may be, and typical myocardial LE pattern in the MRI, and the history, echo and cardiac MRI will help. Takotsubo is typically having a chest pain history or the very stressful delivery or emergency due to fetal complications, will have acute onset during delivery or immediately after delivery, and elevated natriuretic peptides will get, RWMAs will be there, and history and echo can differentiate. Then pregnancy-associated MI, so you will have a history of typical chest pain or epigastric pain, acute onset during pregnancy or immediately after delivery, usually onset. Elevated troponin you will get, and RWMAs according to, and history, ECG, CAG and MRI may help. Pulmonary embolism, so you will have a chest pain and history of unilateral leg swelling, acute dyspnea, acute onset during pregnancy or usually after delivery, and elevated natriuretic peptide and or troponin, and elevated D-dimer you will get. RB dysfunction, RB dilatation sometime, and LV is usually normal, and CT VQ scan can help. Another is the amniotic fluid embolism, so chest pain during or immediately after delivery, or acute dyspnea, acute onset during delivery or immediately after delivery, and elevated peptides and reduced RV systolic function, RV dilatation, and history and echo will help. Hypertensive heart disease and severe preeclampsia, history and echo will help. Hypertrophic cardiomyopathy, so history, echo and cardiac MRI may help. Pre-existing congenital heart disease, you will have the history and echo will help in diagnosis. Pre-existing valvular heart disease, history and echo will help. So diagnosis, PPCM is the common cause, and it is defined as a idiopathic cardiomyopathy manifested as heart failure due to LV dysfunction, and towards the end of pregnancy or in the months after delivery when no other cause of heart failure is found. It is diagnosis of exclusion as per definition given by ESC group. So when we suspect acute PPCM by symptoms during end of pregnancy or months following delivery, dyspnea, orthopnea, peripheral edema, chest pain, dizziness, palpitation, fatigue, depression, cough, then we do the natriuretic peptide, ECG, X-ray and echo, and cutoff value for NT-proBNP is more than 300 and BNP more than 100. And if the peptides are raised and EF is less than 45, then acute PPCM is likely, and we should exclude the other overt pre-existing heart disease like chemotherapy-induced cardiomyopathy, congenital valvular, or HCM. If peptides are raised and EF is more than 45, LV dysfunction is not there, we can think of some other extra cardiac or cardiac causes like pulmonary embolism, amniotic fluid embolism, isolated RV dysfunction, hypertensive disorder of pregnancy, eclampsia, sepsis. If peptides are normal and EF is also more than 45, then consider extra cardiac onset of symptoms like anemia, pneumonia, renal disease, hypertensive disorders, depression, psychological. So management part, PPCM is similar to the standard treatment for other forms of heart failure. Careful attention should be paid to fetal safety and to the excretion of drug or drug metabolized during breastfeeding after delivery. So these cautions should be there when we are managing PPCM. And treatment focus on the reducing preload and afterload and increasing cardiac inotropy. Medication should be continued till LV dysfunction is improved or resolved. Women with PPCM should be treated in the hospital when they have hypotension, worsening heart failure, altered mental status, increased work of breathing. So they should be hospitalized. So heart failure in DCM or PPCM, these are most common causes, can develop rapidly, and guidelines for the management of acute heart failure and cardiogenic shock apply, which are already there like this. We can do, if the patient is in cardiogenic shock or respiratory failure, then we can give pharmacological support, ventilatory support, and mechanical circulatory support accordingly. And if it is shock is not there, then we can identify the acute etiology within 1 or 2 hours. CHAMP-IT is the formula where ACS, hypertension emergency, arrhythmia, mechanical cause, pulmonary embolism, infections, tamponade can be ruled out, and a specific treatment can be started. So for the decompensated heart failure, acute, congestion or fluid overload is there. If hypoperfusion is there, we can, if it is not there, then loop diuretics can be used and can be increased, and renal support can be given. And if it is having a hypoperfusion shock, then inotropes can be added, and vasodepressors can be added, and mechanical circulatory support and renal replacement therapy can be added, and medical therapy continued. For rapid diagnosis and decision making, pre-specified management algorithm and expert interdisciplinary team are very crucial in management of peripartum acute heart failure. So this is algorithm given by Versex et al. And management of acute heart failure during and after pregnancy. I'll come one by one. So initially we should evaluate by, if the, we should assess the acute heart failure severity. If SBP is less than 90 or heart rate more than 130 or less than 45, respiratory rate more than 25, SpO2 less than 90, lactate more than 2 or SCVO2 less than 60, altered mental state, cold skin, oliguria. Patient is acute severe heart failure, cardiogenic shock. And we can confirm the diagnosis by ECG, blood test, natriuretic peptide, echo, and lung ultrasound, and additional tests. So when there is a severe AHF or cardiogenic shock, we should optimize the preload. We should assess the volume status, and accordingly we can give the volume or diuretics accordingly, and vasodilators if SBP is more than 110. Optimize the oxygenation, NIB, ventilation, add inotropes, levosimendan. 0.1 microgram per kg per minute during 24 hours is preferred rather than beta agonist. Urgent delivery or cesarean section, consider bromocriptine in PPCM after delivery, and consider mechanical circulatory support, and if not recovered, think of transplantation. Diuretics, one point is there that they have to be used with caution due to potential reduction in placental blood flow. Management of acute heart failure during pregnancy continues. So stabilized acute heart failure when it is there, then if it is antepartum case, we can give heart failure therapy, hydralazine, nitrates, beta blocker, consider diuretics. And if it is postpartum, then we can think of ACE inhibitor, beta blocker, MRA, diuretics, and ivabradine can be considered, and bromocriptine can be considered, and this bearable cardioverter defibrillator can be given if EVF is less than 35 for initial 6 months. So this is WCD can give benefit for initial 6 months when we are planning of ICD in EF less than 35. This is the members of AHF task force: cardiologist, obstetrician, neonatologist, anesthesiologist, cardiac surgeons, and operating room coordinator. They should be coordinating, and fetus is non-viable, we should do the delivery and manage AHF. If fetus is viable, think of the fetal status and maternal status, and then accordingly delivery or pregnancy is continued. And as I already discussed, we should think of the fetus and along with the mother, safety of the fetus. National Safe Motherhood Day is 11th April. Thank you.